All right, I think we'll get started here. Thanks for joining us, everyone. And my name is Kate Trams, and welcome to the Essential Substance Abuse Skills webinar series. Today, we've invited Sean Baer to speak on clinical evaluation screening. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification exams, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. Our center is a NADAC certified educational provider, and CEUs are available on request for a $15 fee. A request form is available for download in the Files pod in the webinar screen, and we will also be sending this out in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GIPRA evaluation. SAMHSA asks us to evaluate our events and provide improved performance assessment and accountability. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so if you have questions about the presentation, please use the Q&A pod by typing them in the field at the bottom. We will address questions at appropriate points during the presentation. I will also note that you'll see there are 2 pods to the left, or I'm sorry, to the right of the presentation. The Q&A is the one on the top. That one is a place where if you want to submit questions to us anonymously, you can put them there. The chat pod just below, you can comment and put questions, and everyone will be able to see that. So it's a little bit more interactive with everyone else out there, but you can also ask questions there. Today's speaker is our own Sean Baer. He is the Senior Behavioral Health Consultant and Training Coordinator here at the National American Indian and Alaska Native ATTC. And he has been working with Native Americans in substance use for many years. He's an Army veteran and was discharged from the 82nd Airborne. His passion to assist people in overcoming their substance abuse issues, as well as other issues, and to return to spiritual ways of his ancestors has led him to this work, and we're excited to have Sean share this information with you, and I'm going to pass things over to him now.
Okay, hello everybody. Like Kate said, my name is Sean Baer. I'm from Tame, Iowa. I'm with the Meskwaki tribe there. It's good to have you on here today. Okay, so we'll get started here with the introduction and overview. With this presentation, we want to remember that it's focused on a screening process for substance using clients. So the first step in this process is normally to assess a little bit of the client's behavior, their what has been going on in their life, to see whether they meet requirements for an assessment and treatment. Okay, part of a clinical evaluation for the screening process, again, here is what we'll be going through. A little bit of the stages of change, facts about change, the frames model, difference between a screening and the assessment, screening for substance use. Depending upon how much time we have, we might either go to questions then or continue a little bit with the DSM-5 and other treatment options and modalities. Okay, so in the late 70s to early 80s, while working with smokers and how some were able to progress through changes on their own, to successful change, Prochaska and Di Clemente noticed that each had a different rate depending upon the person and the decisions within each person. Okay, so what they found out was that many of the clients would move from pre-contemplation to contemplation, determination or preparation, action, maintenance, relapse, or termination or graduation. But normally, remember that relapse can happen pretty much anywhere, but there are certain places that it may happen a little bit more than others. Okay, so with pre-contemplation, the person has not yet acknowledged or realized there is a problem. You may see this in a client who seems oblivious to the fact that problems with legal, social, personal issues or family arise from the consequences of their use. So they're not considering change because right now they don't recognize there's a problem with the use. Then they tend to move into contemplation, and that's where the person may have come to a realization that there has become a problem with their use, yet they may be ambivalent to make necessary changes. They could be weighing the pros and cons of giving up the use. During this phase, education can be helpful because it helped them to understand that change is difficult for everyone. It doesn't matter what kind of change it is. I mean, many times if we look at ourselves, if we're rushed, normally what happens is that we tend to use skills or coping skills that we have used in the past because we know they work. And it's the same kind of thing with clients. So they have learned to use certain kind of behaviors or whatever it might be to get them through certain kind of issues in their life. Okay, so then we move into the determination or preparation stage. And well, the person is getting ready to change and making commitment to change. Such a client we might see come to treatment and wants assistance with that process. So at this time, they're becoming more committed and they're committing to that change. They made a decision. They want to do that. Once they do that and enter into the processes of making that change, then they enter the action phase. And it's also can be called the willpower stage. They believe they have the ability to change and beginning to utilize techniques to change. This change is when we normally see them in treatment, yet this is also the stage that is considered the greatest risk of lapse or relapse. Remember that a slip can also be a great time to find a teachable moment. I mean, if you look at many of the clients, they might have a lapse or something. They're kind of beating themselves up, wondering how they made such a mistake. But to me, I've always kind of seen when they're looking bad about that, it's a great time to be able to teach them things. It's a good thing, I thought, was that they felt bad about it. I would be more concerned about those that didn't feel bad about it. So sometimes they may want to give up, but it's a great time to let them know to keep going. Give them that strength with them, give them that support with the tools and stuff like that. And remember that they need to look at how far they've gone as well, and the actions and the decisions they've made in their life and the different changes as well. So after this, we move into a maintenance with relapse or cycle and recycle. So if we look at this, it's a time to reflect on how far they've gone. Through relapse prevention skills and patience, they're able to better utilize self-awareness skills and avoid those relapses. If they're able to anticipate certain situations and circumstances that may happen, it can help them. It's a really great time to be able to teach them coping strategies. Remembering that relapse in that change is difficult. Remember the first time you might have maybe fell off your bike when you were a young kid when you tried to learn how to ride. You may have felt beaten, maybe discouraged, maybe you thought maybe your friends might be laughing, or brothers or sisters, whoever it might be, but usually an encouraging adult or person helped you to try again and again, and eventually you did it. You learned that being around risky situations, it can lead to a fall or a relapse. Yet being around supportive people can make you stronger. So part of this is also learning. By maintaining in the maintenance stage long enough, you are able to reach higher levels and begin to understand yourself better. You reach what is called a stage of transcendence to a new life. And if we're looking at the longer a person is abstinent from substances, because remember they are mind altering, we look at some of the chemical changes that are going on in the brain. Many of these target reward centers of the brain. So a lot of times they make us feel good at times when maybe we shouldn't. So they kind of trick us into believing that it's helpful. No picture here. Let me see. Okay, so let's see. Okay, so some facts about change is that change can be difficult for anyone. It's something we need to remember, not just for us, but our clients. When we feel others are supportive and caring, we seem to tend to try harder. You might think about times when you were in school, especially when younger, or even college level. Many times if you liked the teacher, if they seemed very supportive of you, we tended to try harder for them. You might have paid attention more because you've learned to respect this teacher. But many times within the counseling atmosphere too, the clients may tend to feel that same way. So there's a time when beginning to learn and utilize empathy with our clients. And it reminds me a bit of grad school when we were going through empathic listening skills and by this instructor. She was really good at it. And I remembered that it was very similar to the way that I had learned growing up, because there was a certain point where I would see things happening to other students. Maybe they were being bothered by others or kind of teased, or sometimes maybe you see some being bullied. But what I then did was to pretend it was me they were bothering. And as soon as I felt that, well, I didn't want to be alone. I would want somebody to help me. So right away I stopped, walked over and helped the person. So it can be beneficial if we're able to kind of put ourselves in the same kind of place that, in our mind, of course, what the client is saying helps us to have that empathy towards with them. So practice positive self-talk with these clients. We learn to speak good things of ourselves and to the client, and helping them to be able to keep going, not not letting them be able to say those kind of sentences or words where they're beating themselves down. I mean, if you look at older teachings with the tribes, they seem to have this knowledge that words had a sense of power. They could say certain things and it would happen. So we remember when we were speaking to clients or even to ourselves, or the clients speaking to themselves, we should try to say good things about ourselves. Okay, so then we're going to get into a little bit about micro counseling and motivational interviewing here. Let me see. Okay, so you'll see that micro counseling skills developed by Alan E. Ivy. Okay, so with micro counseling skills, these can be used to enhance the communication with clients. By utilizing these, it helps to build an alliance and engage clients in a meaningful discussion. So remembering how we speak to the clients, remembering our body language. We have verbal language, nonverbal language, remembering that clients tend to be able to look at those. And if you look at many of the youth who are coming from maybe a behavioral treatment place, or those who are coming from a family where there had been violence or anything like that, and even natives, they're very well versed in body language and how certain things can mean certain things. So even just one eye movement or a movement from any part of the body can let them know that maybe this person doesn't really totally believe, or they may actually become a little defensive with the client themselves. So try to keep an eye on that when you're with clients. Okay, so attending behavior. People want to feel heard, and you are interested in what they're saying. So when somebody's speaking to you, if they're kind of looking off in the distance or they seem inattentive, we may tend not to say as much. So many times we need to be able to lean forward to this person. You can also use mirroring with the client, and that is just sitting in the same position as the client is. So if they move to a certain position, you move to that position. And somehow it's like being with the client a little more than just sitting and listening to them. And the client's going to notice this, whether they're conscious of it or not. And a lot of times it begins to may make the client feel like this person is really with them then. So using open-ended and closed-ended questions. So you want to make sure that when you are with the client, to make sure not to over question them. Do not bombard them or grill the clients. Don't ask multiple questions all at once before you get an answer. Remembering not to use questions as statements such as, don't you think it would be helpful if you did more? Or don't you think it would be helpful if you stopped? It can tend to make the client a little defensive. So also remember cultural differences and also age differences. One thing that is really kind of neat with this part is that it tends to go along with some of the teachings with natives, because they ask you not to ask the questions of why. It may lead them to become a little defensive, The way I was taught is that you ask, how come? Or how is this? And those kind of questions are going to elicit more of an answer than just yes or no. Okay, so remembering that nonverbal behavior is approximately 85% of all communication. Looking for discrepancies with the clients, either mixed messages, contradictions, conflicts, incongruities. You may have noticed with the natives that they're perceptive of all the body language. A lot of the youth will too. Sometimes even just a certain movement may make them on edge or something. Like I said before, you might see this in a lot of youth treatment or behavioral, with behavioral youth. Something you might learn to look at is with youth, especially if they've gone through either trauma, problems in their home, whatever it might be, is they begin to almost like build defenses with themselves. They're going to be very perceptive of everything that's going on around them. Even tone of voice or whatever, even looks or however a parent might be doing something. So sometimes what they might be doing also is transferring that onto the client. So what are the counselor? So they may end up seeing the counselor as similar with the parent or another adult that treated them bad. Okay, encouraging, paraphrasing, and summarizing. With encouraging, it's intentional listening. You might say yes or nod your head, um, kind of smiling, said yes, of course, some things like that that helps them, encourages them to speak more. Paraphrasing is not just repeating what the client says, but capturing the essence of what they had said. So it's putting that key things within what they just told you back to them, but much shorter. And it helps the client understand that you are listening. If you get it wrong, just ask the client to explain that to you. You can even say, is it like this? And a lot of times if you get it right, they're really going to kind of come alive and see that you're listening to them. Summarizing, they're more brief of the whole counseling session, using, of course, those key parts of the communication as accurately as possible. So a lot of times, if you look at a counseling session, in the beginning you're going to be using encouraging things to get them to speak more, to elicit more talk. Paraphrasing is now and then to sum up everything in a little bit. But summarizing is at the end, when you're just gathering the whole session all at once and letting them know that you are listening, but asking if that is correct. And a lot of times, if you're correct, it helps the client realize that you are listening and you care. Okay, so reflecting feelings. You might have also heard it called reflection of feelings. Remember not to overanalyze the client or to minimize things. It might come up saying that must have been very difficult. That must have been a very difficult decision. You must have felt abandoned or alone. So these are things that haven't really been stated, but it's something that they might have felt during those times. So they might have explained to you what was going on, and it's kind of like if you can pretend that's you like I had said before, when I'd noticed other students being bothered or something like that, kind of things came to me saying, oh, this is the way I would feel. And sometimes it can be correct, sometimes maybe it's a little bit different, but it also allows the client to know that you might possibly know how they are feeling. Okay, reflection of meaning is a little bit different, but let's say a parent or loved one is speaking with you and they're getting upset about maybe a child's decision to go to a certain college or university, or maybe decisions about certain things in life. So you might say, wow, you must really love your child. You must really care for your child and feel that here she is making a big mistake in their life. Or you might say you must really love and care for your child, but and you're feeling this way because you're going to miss them. So at times the client might say, yes, exactly. You know, it helps them to know that you might understand. It helps them to open up a little more and elicit more talk about those feelings and what's going on. Sometimes if we look at listening to clients, they might not even know what they're feeling. So it really helps to be able to get a little feedback from somebody else too. So with empathy, like I said before, it's placing yourself in another's moccasins. It helps you to understand a condition or experience from their own perspective. And when you can say that and speak about those feelings or emotions that are elicited during those times, and it's very similar to theirs, they're really going to believe that you understand and that you can help them with their problems. But again, I guess I don't never really like to say I help clients. My best thing is I've always kind of come to the realization that I assist clients. Helping them is just kind of giving the answer, while assisting them is helping them to come to the right conclusion on their own. Okay, so we're going to get into a little bit of motivational interviewing. Okay, so you'll see that William Miller originally developed motivational interviewing. He was working with those who, let me see, with alcohol and substance abuse, but help people resolve their ambivalence and move forward. Um, to help them make healthy changes in their lives. So he found that by certain use of words, motivating the client, help them to come to the conclusions on their own. So you'll see through this part here, it reminds me much of the saying, wisdom is to know others, but enlightenment is to know thyself. So from a certain point, we tend to think that we know certain things about certain people, but the hardest things is to know ourselves. And when we are able to look further into ourselves, it helps us to think differently about it. Many times the things that bother us is more so about us than it is somebody else or a certain situation. Okay, so motivational interviewing is a client-centered approach. Increase the client's response to screening and assessment, improves the treatment outcomes by enhance enhancing motivation to change. Okay, so with the rationale, the therapist creates an atmosphere that is conducive to change by expressing empathy, demonstrating non-judgmental understanding of the client's perspective. Kind of to sum it up. If we look at making sure that you pay attention to the time, certain strategies at certain times, maximizing the effective use of these skills can really help. A lot of times if you just practice more of it, you get better and better at it. Okay, so 2 phases of MI, assistance, screening, assessment, client change, is building motivation for reliable assessment, significant changes. So asking those open-ended questions, using affirmations, reflections, and summarizing. Strengthening commitment to change is build upon the client's motivation. Find out what motivates them. That'll help them move forward and help them resolve things that might be stopping them from change. So a lot of this can be using like positive talk. It'll help them. Okay, so we get into the basic principles of motivational interviewing, and you'll see that empathy is a lot like being non-judgmental. Developing discrepancies is helping to explore gaps between behavior and the life they would like to lead. Role with resistance involves accepting ambivalence and inviting the client to enter the process of problem solving for themselves. Sometimes what we can do is to help them through that, give them a little help with that. Self-efficacy, optimism, encourages the client's sense of possibility of change. Try to avoid any argumentation or confrontation. A lot of times you'll see that when somebody gets angry, they're normally not going to be listening anyway, and you'll see that a lot with behavioral youth. Once they become angry, you might as well not even speak to them. Let them calm down. Once they calm down, get them to talk about positive things, and then get a little bit deeper into what's going on, and then they'll usually speak to you. Okay, so motivational interviewing. See, we've looked at the fundamental approach, the 4 principles. So then by doing this and collaborating with the client, we might be able to assist the client through the change. It's kind of like walking with them, being actually with the client and not just in 2 different spots or something like that. It's really interacting with the person. Okay, so then we get into the frames model, which the F, of course, is for feedback. Sometimes the client may need feedback. Looking at risks they're doing, such as, are they driving while they're drinking, or use of drugs or anything like that? Is there any other risk that's going on involved? Anybody can be hurt, not just themselves. Looking at the responsibility of the patient, or client, making sure that we remember that much of the responsibility for change is with the client themselves. We can give them advice to change. We can help them have a whole array or a menu of ways to reduce drinking. It's really good for using coping mechanisms, coping skills. Sometimes when they're going to be out with friends or something like that, helping them to already have answers to give to their friends, something so they don't have to think about it on the spot. Be empathetic, remembering that all clients deserve self-efficacy. Okay, so we're looking at screening and assessment. Now, if you're looking at the time that goes on, it gets more and more time. Of course, cost is going to be more as well. Screening is normally very short. From that time in screening, you'll be able to find out whether the client meets any of the criteria to go on further for an assessment, or whether they need treatment. Um, Remember that from a screening, it does not always mean that the client needs an assessment. It's just the tools of being able to find those people who do. So then we get into the assessment and get further into assessing the client. And from that assessment, we develop a treatment plan for them. Okay, so screening, if you look at it, is designed to reflect the likelihood of a presence of substance use. Assessment is designed to provide a broader range of information on degree, kind, causes, possible treatments of the use. So assessment kind of leads to, or screening kind of leads to an assessment, but assessment normally is when you're going to be getting a lot of information from either what has happened in their past, their medical, their family, looking at the history of this client and this person and finding exactly who they are. Okay, so screening is normally brief, and so are the instruments. Normally they require yes or no. They can be administered by lay people, paraprofessionals, or non-experts. Assessment instruments, a little more complex, definitely more time consuming. Depending upon the kind of assessments you're doing too. They may need to be done by an experienced examiner. So those who are just asking certain questions and you can't describe anything like that, that's one type. But there's another one where you need more experience to be able to further those questions and maybe even change them a little bit. Okay, so screening for substance use disorders, a lot of what they use is might use the cage, wraps, the mast, the taste or tweak, looking for behavioral observations, looking at the client when they answer these questions, looking at collateral information such as friends, relatives, people who know them, maybe past employees or employers, looking at laboratory tests, UAs, saliva tests, whatever it might be. Okay, so the cage is this 4-question questionnaire with the acronym CAGE. The C is for cut down. So have you felt you should cut down? So it's going to be kind of looking at a little, are they feeling guilty? Have people annoyed you by criticizing your drinking? So in a little bit worried, they might be worried about you. Have you felt bad or guilty about your drinking? Have you ever had a first drink in the morning? So that's the eye opener. And you'll see that many of these tools here ask many of the same things. So the wraps, of course, do you feel remorse? Amnesia, so that's close to blackouts, but amnesia is saying it a different way. so that they won't become defensive and try to hide it from you. Have you failed to do what was normally expected of you because of drinking? So that goes along also with the DSM. Do you sometimes take a drink in the morning? So remember the starter, an eye opener. Okay, and you'll see through here with the mast, it's asking very similar questions, the first part of it. So you'll see that with here, number 6 is, have you attended a meeting of Alcoholics Anonymous? Has a heavier score, but that's related to past use, the history. Okay, so the mass 2, you'll see again, many of these are similar to the other questionnaires. Then we get into the TACE, which is screening for pregnant women. So the T is for tolerance, feeling annoyed. You ever felt that you should cut down or had an eye opener? And the other one, which is the tweak, is very similar. You'll see that T is for tolerance, worried, eye opener, amnesia, and the K, of course, is for feeling that you should cut down. Okay, so looking at substance-related disorders in the DSM-5, remember that we need to be familiar with these and how to look at if somebody would meet the requirements of that. So when we're able to look at those, we can look a little bit further into what might be happening within the client. So if somebody comes in, you might also find that instead of just cannabis related disorder, they might also have a tobacco related disorder or something like that. Okay, so almost all the substance related disorders of DSM-5 include substance use, intoxication, and withdrawal, but there's also specifiers of mild, moderate, or severe. There's exceptions are caffeine use disorder, hallucinogen use disorder, inhalant use disorder, and tobacco use disorder. So sometimes these come in handy because if a client comes in your office, has been using certain kind of drugs, but there's no intoxication or withdrawal, then you know that it could be a hallucination disorder. Or if there's no intoxication, then there's also inhalant use. And inhalant use, even though there's no intoxication, there is also damage going on, because when the body through inhalants, it's kind of robbed of the oxygen flow. That is stopped. Okay, alcohol-related disorders could include alcohol use disorder, mild, moderate, severe, intoxication, or withdrawal. So many of the times, many of us probably won't be doing an assessment or screening for those who are intoxicated, but sometimes it can be happening maybe in detox or withdrawal. Remembering that the distinction between alcohol abuse and dependence has been eliminated in the DSM-5. So that's a DSM-4 criteria. Information. Okay, so With the DSM-5, you have to have at least 2 symptoms present in order to have a mild use disorder, and 6 or more is severe. So also looking at those is to remember that it has to happen within a 12-month period. We're looking for problematic patterns of use, which lead to clinically significant impairment or distress. And the big thing is clinically significant. So that is part of the changes within the criteria. So here are the symptoms of alcohol use. I think many of you had probably seen many of these in the DSM-5 already. But this part here is to let you understand a little more of the things you need to understand in assessment process. Looking at those in checking out your client. So sometimes if a person says within 2 hours they had 10 beers or 5 beers, we understand that, for each drink it takes an hour for the body to eliminate it. Looking for different things that the client may say might be very similar to these. Whether a new symptoms, it's cravings. So that's the urge to use. Continued use despite having persistent recurrent social problems. Many times the client may end up saying that they don't have any kind of social problems, yet maybe if they have a problem with their spouse or family, it's also a social problem. Okay, so again, with these here, we're looking at tolerance and withdrawal. So remembering that tolerance is a need for markedly increased amounts of alcohol to achieve the same or desired effect, or they might end up having a diminished effect with the same amount. Withdrawal, you have to understand and look at all the withdrawal symptoms for all the substances, but this one here is for alcohol, so you don't have to know those. Alcohol or related substances such as benzodiazepines, to look at those things. What's very similar with alcohol use disorder is gambling disorder. So you'll see here the specifiers. A lot of these have been changed, except let me see, patient status specifiers a little. Early remission, sustained remission, controlled environment. And remembering that with an assessment process, a controlled environment does not count for remaining abstinent from that substance because they didn't have a choice. So all substance use disorders in DSM-5 include specifiers. Okay, so we still do have a little time. We might just be able to push forward. It's not that much left. Treatment options. If a client comes in, they might need detox, so they might have to go to detox before they actually come in to do an assessment. Pharmacology. So we might look at whether a medication might assist them. If their diagnosis is not too severe, Outpatient might be helpful, or extended outpatient, or intensive. They might need partial hospitalization or residential. Of course, after these, or sometimes they might need just aftercare support groups. Okay, so remembering to use evidence-based treatments for substance use disorders. Motivational enhancement therapy has been very helpful, along with CBT, 12-step, community reinforcement, behavior couples therapy, pharmacological treatments. Remember that through this is that with evidence-based treatments, motivational interviewing heightens motivation to stop abusive drinking by providing patient objective feedback. But also, motivational interviewing works very good with Native Americans. It's very cultural in a sense by helping them like that, and they respond very well. So let me see. I know I had spoken about 12-step facilitation before, and its involvement with the AA, community reinforcement approach, access to community resources. You might be able to have people within the community that can help. Utilizing therapy with the spouse or loved one can be very helpful as well. Remembering that normally substance use issues has normally been a family problem, not just one person's problem. Here are some of the pharmacology medications that can be used. Okay, looks like we got about, I think, around 7 minutes or so left. If you have any questions or comments, please go ahead.
Thank you so much, Sean. And we have some time for questions, so please submit those in the Q&A pod, and we will get to those as soon as we can. I just want to remind everyone, while we're waiting for questions to come in, that we will be sending follow-up emails, which will include the link to the recording of today's webinar, a link to the survey in case you don't get directed to it as we close out, and then also the CEU request form and handouts of this presentation. Excuse me. And let's see. I would just like to encourage those who are joining us because they're studying for the certification exams. We have all of our recorded webinars in this series available on our website, so you can review those at any time, and those are really helpful in preparing for your exams. And it doesn't look like we have any questions at this point, so I'm gonna just give back to Sean. Is there anything else you'd like to say before we finish up?
Not necessarily at this time. I thank you all for listening in today. And if you are getting ready to take your exam, good luck with that.
Wonderful. Yes, thank you so much, Sean, and thanks again, everyone, for joining us. And with that, we hope you all have a good day. Thanks so much.